Good evening, teachers, senior colleagues, and friends. A warm welcome from the Caritas Neurosciences team to all of you for joining this webinar on acute stroke management. And I am Dr. Joseph Sebastian, a consultant neurologist at Caritas Hospital, Kottayam. World Stroke Day is observed on October 29th, coming this Thursday, and to increase awareness for the prevention of stroke and the newer advances in acute stroke management. So our purpose of this webinar is to increase awareness among our physicians and the doctors about the recent advances and the immediate care. What should we do in if a patient comes with stroke, which is a very common and a very disabling condition. Before starting the webinar, meet our director, Reverend Father Dr. Binu Kundat, who is also the president of CHAI. Over to you, Father.
Yeah, very good evening. It's Caritas Hospital Department of Neurosciences webinar stroke practical approachment and management. തീർച്ചയായിട്ടും അത് പങ്കെടുക്കുന്നവർക്കും കേൾക്കുന്നവർക്കും എല്ലാം ഒരു അനുഗ്രഹമായിട്ട് മാറട്ടെ എന്ന് ആശംസിക്കുന്നു, പ്രാർത്ഥിക്കുന്നു. അതുപോലെ പ്രത്യേകിച്ച് ന്യൂറോ ഡിപ്പാർട്ട്മെന്റിനോട് ചേർന്ന് നമുക്കറിയാം PMR-ഉം ഇന്റർവെൻഷൻ റേഡിയോളജിയും ക്രിട്ടിക്കൽ കെയറും ഒരുമിച്ച് ചേർന്ന് സമഗ്രമായ ഒരു ചികിത്സാ സമ്പ്രദായം കാരിത്താസ് ആശുപത്രി ന്യൂറോ സയൻസസിൽ വിഭാവനം ചെയ്യുന്നുണ്ട്. പ്രത്യേകിച്ച് എല്ലാവരെയും ഇതിൽ പാർട്ടിസിപ്പേറ്റ് ചെയ്യുന്ന എല്ലാവരെയും അഭിനന്ദിക്കുന്നു. അതിലുപരിയായിട്ട് ഇങ്ങനെ ഒരു ഇനിഷ്യേറ്റീവ് എടുത്ത ന്യൂറോ ഡിപ്പാർട്ട്മെന്റിന് എല്ലാവരെയും അഭിനന്ദിക്കുന്നു. പ്രത്യേകിച്ച് അണ്ടർ ദ ലീഡർഷിപ്പ് ഓഫ് ദി ഡോക്ടർ ജോസഫ് സെബാസ്റ്റ്യൻ. It's a really wonderful personality under whom our neurosciences department is growing every day. Same time, thank you very much for all the participants and all the doctors, supporting doctors in and around the central Travancore who is participating and joining this today's webinar. Really appreciate for everybody's work together. We will overcome every obstacles and we will encourage this knowledge and the technologies towards the cure of the patients. So wish you all the best. God bless you. Thank you.
Thank you, Father. Thank you. So let us go directly to the content of the program. As you all know, stroke is a very common and disabling neurological condition, and it happens due to the interruption of the blood supply to the brain, and it can be due to the blockage of the blood vessel, which can cause the ischemic area or the blood supply to the brain is interrupted, which you can see in the left side of the slide, where you can see the dark area where the brain tissue has damaged. On the right side, you can see there is a rupture of the blood vessel and there is a bleed, where you can see the white area in the brain. So stroke is a serious condition. More than the seriousness, it can cause severe morbidity. And there are two types of stroke, the ischemic stroke and hemorrhagic stroke. So it's a very vast topic. So what we have planned in the next 1 hour is that our senior consultant neurosurgeon, Dr. Sareesh Kumar, will be moderating the stroke. He has selected some of the key questions in the acute stroke management, which will be discussed by our panelists. The panel comprises of our neurologist, Dr. Deepak Devarajan, our senior neurosurgeon, Dr. Dr. Lijo, as a consultant neurologist, Dr. Somsaran, our interventional radiologist, Dr. Anju, Devasia is our intensivist, and Dr. Sheila is our rehabilitation specialist. Over to you, Dr. Sareesh.
Thank you, Dr. Joseph, for the nice introduction about acute stroke management, recent concepts. And we Caritas Neuroscience Department is going to present the webinar about the practical approaches of acute stroke management. Dr. Joseph already discussed about types of stroke. We have two scenarios in ischemic stroke and a hemorrhagic stroke. We all know that stroke is one of major leading cause of morbidity and mortality in our subcontinent. And we are going to present these concepts of stroke. We all know time is brain. It is the importance of time in stroke management. That is mentioned in the sentence, time is brain. And we are also going to discuss about stroke mimics and initial management of stroke. What are the gold standard treatments of stroke, and what are the early imaging signs that we can pick up in a peripheral setup, and what are the techniques for acute stroke management. Like we have thrombolysis techniques, we have thrombectomy techniques, and the recent advances in neurocritical care and neurorehabilitation. These things we are going to discuss. And the impact of stroke in our society. In India, we know that every 3 Indians suffer a stroke every minute. Most of these strokes, we don't identify it in proper time. In the worldwide statistics, about 20 million people suffer from stroke everywhere in every year. And in India, around 1.5 million people suffer from stroke every year. നമുക്കറിയാം stroke causes more deaths in the country, in our country. ഇന്ത്യയിൽ മലേറിയയിലും ട്യൂബർക്കുലോസിസും ഓർ HIV ഉണ്ടാക്കുന്ന ഒരു കമ്പൈൻഡ് ഡെത്തിനേക്കാളും കൂടുതൽ പക്ഷാഘാതം അഥവാ സ്ട്രോക്ക് കൊണ്ട് ഉണ്ടാകുന്ന ഡെത്ത് സംഭവിക്കുന്നുണ്ട് എന്നുള്ളതാണ് എല്ലാ സ്റ്റഡീസിലും കാണിക്കുന്നത്. So the impact of stroke in our country is very high, and we have to give more importance to the preventive aspect and the immediate treatment aspect of stroke. So it means, what is the meaning of time is brain? It means more than 30,000 neurons die for every second delayed in stroke. പക്ഷാഘാതം വരുന്ന ആളുകളിൽ ഓരോ സെക്കൻഡിലും more than 30,000 neurons ഡെത്ത് ആവുന്നുണ്ട് എന്നുള്ളതാണ് അതിന്റെ ഇമ്പോർട്ടൻസ്. സോ വി ഹാവ് ടു ആക്ട് ഇമ്മീഡിയറ്റ്ലി. എത്രയും പെട്ടെന്ന് ഒരു സ്ട്രോക്ക് ലക്ഷണങ്ങൾ കണ്ടു കഴിഞ്ഞാൽ വി ഹാവ് ടു ആക്ട് ഇമ്മീഡിയറ്റ്ലി. എത്രയും പെട്ടെന്ന് ആക്ട് ചെയ്യുക എന്നുള്ളതാണ് ടൈം ഈസ് ബ്രെയിൻ എന്നുള്ളതിന്റെ ഇമ്പോർട്ടൻസ്. There are some stroke mimics. സ്ട്രോക്കിന്റെ പോലെ തന്നെ ലക്ഷണങ്ങൾ കാണിക്കുന്ന ചില ഡിസീസസ് ഉണ്ട്. ഫോർ എക്സാമ്പിൾ ഹൈപ്പോഗ്ലൈസീമിയ. ശരീരത്തിലെ ബ്ലഡ് ഷുഗറിന്റെ അളവ് വളരെ സിഗ്നിഫിക്കൻ്റ്ലി കുറഞ്ഞു പോവുകയാണെങ്കിൽ അവർക്ക് സ്ട്രോക്ക് ലക്ഷണങ്ങൾ കാണിക്കാം. അതുപോലെ തന്നെ പെരിഫറൽ വെട്ടേഗോ ഉള്ള ആളുകൾക്ക്, മൈഗ്രെയിൻ ഉള്ള പേഷ്യൻസിന് ഹെമിപ്ലീജിക് മൈഗ്രെയിൻ എന്ന് പറഞ്ഞ ഒരു സ്പെസിഫിക് സിനാരിയോ ഉണ്ട്. ഓറയുടെ കൂടെ പ്രസന്റ് ചെയ്യുന്ന സിവിയർ ഹെഡേക്ക് വിത്ത് വീക്ക്നെസ് ഓഫ് ബോഡി പാർട്സ്. അതുപോലെ തന്നെ പോസ്റ്റ് സീഷർ പേഷ്യൻസ്, ടോട്ട് പാരാലിസിസ്, പോസ്റ്റ് ഇക്ടൽ ഡെഫിസിറ്റ്, ദേ മേ ഡെവലപ്പ്. ഒരു ഫോക്കൽ സീഷർ വന്നു കഴിഞ്ഞാൽ ആ സൈഡിൽ വീക്ക്നെസ് പ്രസന്റ് ചെയ്യാം. ഹൈപ്പർടെൻസീവ് എൻസെഫലോപ്പതി, വളരെ സിഗ്നിഫിക്കൻ്റ് ആയി ഹൈപ്പർ ടെൻഷൻ വരുന്ന ആളുകൾക്ക് എൻസെഫലോപ്പതി ചേഞ്ചസ് വരാം. ആ ഒരു സ്ട്രോക്കിന്റെ പോലെ തന്നെ സിമിലർ പിക്ചർ പ്രസന്റേഷൻ ഉണ്ടാവാം. പിന്നെ തലച്ചോറിൽ ഉണ്ടാകുന്ന മുഴകളോ, വളരെ അപൂർവമായി സൈക്കോളജിക്കൽ പ്രോബ്ലംസ്, കൺവേർഷൻ ഡിസോർഡേഴ്സ് ഉള്ളവർക്കോ കൺവേർഷൻ റിയാക്ഷൻസ് ഉള്ളവർക്കോ സ്ട്രോക്ക് മിമിക്സ് ആയിട്ട് പ്രസന്റ് ചെയ്യാം. സോ വി ഹാവ് ടു ഐഡന്റിഫൈ stroke properly, and we have to differentiate stroke mimics. That is also very important. So നെക്സ്റ്റ്, നമ്മൾ എങ്ങനെയാണ് സ്ട്രോക്ക് മാനേജ് ചെയ്യുന്നത്? ഒരു സ്ട്രോക്ക് പേഷ്യൻസിനെ ഐഡന്റിഫൈ ചെയ്ത് കഴിഞ്ഞാൽ എങ്ങനെയാണ് മാനേജ് ചെയ്യുന്നതെന്ന് ചോദിച്ചാൽ ഡോക്ടർ ദീപക്, നമ്മുടെ ന്യൂറോളജിസ്റ്റ്, അതിനെക്കുറിച്ച് ഒന്ന് സംസാരിക്കും. ഡോക്ടർ ദീപക്, can you proceed with initial management of stroke?
Thank you, Dr. Sareesh. Stroke is an emergency. So like any emergency, the initial management is similar. We have to always look for ABC, or you have to look for airway, you have to look for breathing, and you have to put an IV line and look for vitals. In case of stroke, there will always be some involvement of the muscles of swallowing. So let us do everything to prevent aspiration in time of a stroke. For that, it would be better if you can keep the head end elevated at about 30 degrees. So it will prevent aspiration to some extent. And after putting IV line, we have to give fluids. And when we give fluids, it is always preferable to avoid dextrose containing fluids, because hyperglycemia can worsen stroke, and also 5% dextrose. It can also increase cerebral edema if the stroke is big. Coming to aspirin, there is no urgency in giving aspirin. We have to wait. We can wait till the imaging is complete, until we can identify what type of stroke it is, whether it is a hemorrhagic stroke or it's a thrombotic stroke. Coming to blood pressure management, again, if in case of blood pressure, in case of a thrombotic stroke, we don't have to bring down the blood pressure fast, unless, because normally during a thrombotic stroke, the blood pressure can go up. So if unless the blood pressure is above about 220 to 120 millimeters of mercury, there is no urgent need to bring blood pressure down. The case is different if you are planning to give thrombolytic therapy. That is, if we give TPA, there we have to keep a lower range. We have to keep the blood pressure below 185 to 110 before TPA administration, and after TPA administration, the blood pressure needs to be less than 180/105. Otherwise, there is an increased risk of bleeding. But the case is different in case of an intracranial hemorrhage or in the case of a subarachnoid hemorrhage, where you have to keep the blood pressure low. It has to be kept under 160/100 millimeters of mercury in case of an intracranial hemorrhage, maybe a little lower in case of subarachnoid hemorrhage. Coming to mannitol, I mean, we don't have to give mannitol for every patient with acute stroke. So it's not really required to use prophylactically for acute stroke. In case there are the use of mannitol can be used in two different situations. One, in case of an ischemic stroke, what we are giving, why we are giving mannitol is to prevent cerebral edema, to prevent complications of cerebral edema. So in case of a large ischemic stroke, usually the cerebral edema develops in 2 to 7 days. So to prevent that, we can give mannitol in large ischemic strokes. In case of an intracerebral hemorrhage, the cerebral edema can happen earlier. So in case of a hemorrhage, you can give mannitol even earlier. But in case of an ischemic stroke, there is no urgent need to give mannitol. Coming to anticonvulsants, we don't have to give anticonvulsants in all patients with stroke. Yeah, seizures can occur in approximately 2 to 33% of acute stroke patients. It can be given prophylactically. We can give, as a practice point, we can give antiepileptics in 2-3 conditions. One, if the ischemic stroke is involving the cortex, or if the stroke is hemorrhagic, or if the GCS score is very low, there we are justified in giving antiepileptics, but we don't have to give it in every patient. The preferable antiepileptics could be levetiracetam, lacosamide, and in some cases we can give phenytoin also. These are the common things that we usually give following stroke. Coming to the next problem, that is blood sugar levels. Now, blood sugar levels can severely affect the prognosis of the present stroke in 2-3 mechanisms. One, it can produce anaerobic metabolism and it can directly result in damage. Second, it can cause free radical generation. Third, it can increase the blood barrier permeability. So these are the ways in which hyperglycemia can affect. The recommendation is we have to aggressively treat hyperglycemia. Even hyperglycemia can mimic stroke. So how to aggressively treat? Yeah, always you have to keep the blood sugar levels below 180 milligram per deciliter. It can give insulin at higher levels also. And the range should be in the range of approximately 140 to 180. That would be the most appropriate.
Thank you, Dr. Deepak, for giving the wonderful initiate treatment plans. നമ്മൾ പെരിഫറിയിൽ ഒരു പേഷ്യന്റിനെ കാണുമ്പോൾ സ്ട്രോക്കിന്റെ പിക്ചേഴ്സ് ഉണ്ടെങ്കിൽ ബി ഫാസ്റ്റ് എന്ന് പറഞ്ഞാൽ ന്യൂമോണിക് ഓർത്തിരിക്കുന്ന എപ്പോഴും നല്ലതായിരിക്കും. ബി എന്ന് പറയുന്നത് ബാലൻസ്, ഐ ഡീവിയേഷൻ, വിഷന്റെ പ്രോബ്ലം, ഫേസ് ഡീവിയേഷൻ, ഫേസ് ഒരു സൈഡിലേക്ക് ചെരിഞ്ഞു പോവുക, നമ്മുടെ ആമിന് വീക്ക്നെസ് വരിക, സ്പീച്ച് പ്രോബ്ലംസ് വരിക, ഇങ്ങനെയുള്ള ലക്ഷണങ്ങൾ, സ്ട്രോക്കിന്റെ ലക്ഷണങ്ങൾ കണ്ടു കഴിഞ്ഞാൽ ഇമ്മീഡിയറ്റ്ലി ചെയ്യേണ്ട കാര്യങ്ങളാണ് ഡോക്ടർ ദീപക് ഇപ്പോൾ എക്സ്പ്ലെയിൻ ചെയ്തിരിക്കുന്നത്. അപ്പോൾ നമ്മൾ നെക്സ്റ്റ് ഫേസിലേക്ക്, അതിന്റെ ട്രീറ്റ്മെന്റ് പ്ലാനിലേക്ക് കിടക്കുമ്പോൾ, ഒരു അക്യൂട്ട് ഇസ്കീമിക് സ്ട്രോക്ക് വന്ന ഒരു പേഷ്യന്റിന് എങ്ങനെയായിരിക്കും, ഡോക്ടർ ലിജോ നമ്മുടെ ന്യൂറോളജിസ്റ്റ് ആണ്, ഡോക്ടർ ലിജോ എങ്ങനെയായിരിക്കും അതിന്റെ ട്രീറ്റ്മെന്റ് പ്ലാൻസ് എന്നുള്ളത് ഒന്ന് പറയാമോ? എന്തൊക്കെയായിരിക്കും അതിന്റെ ട്രീറ്റ്മെന്റ് പ്ലാൻസ് എന്ന്?
Thank you, Dr. Sareesh. And we spoke till now regarding the initial management. Then comes the imaging. So only imaging can distinguish ischemic stroke from a hemorrhagic stroke. So we are dealing with the ischemic stroke. So we have done an imaging and we know that it's an ischemic stroke. So previously, the focus was on the parenchyma. We used to get a brain imaging and see the damaged area. But after 1996, with the advent of intravenous thrombolysis, we understood that the problem is not in the parenchyma. The problem is in the pipes, the vessels. So all treatment should be focused in restoring the blood flow in the pipes. So here comes the importance of revascularization strategies. So the first set is very important. We used to give antiplatelet loading dose in every case of stroke. Does that change the thrombus? No, it will only prevent further progression of the clot. So whatever clot is formed, to clear that, we need to use revascularization strategies. So which comes in which the intravenous thrombolysis comes and the mechanical thrombectomy comes. And all the other strategies, we used to give heparin initially, we used to give clopidogrel, aspirin, statins. All these are only supportive, and this alone will not change the prognosis of the patient unless you open up the vessels. And along with this, we need to use other supportive measures to reduce free radical injury. Then if there is raised ICP, we need to address that as well. So this slide is based on the time window. So again, the area of stroke is fast changing. We used to focus on the time window when these guidelines came. So as per this time guideline, we can give intravenous thrombolysis through a peripheral line. We can administer Actylyze or tissue plasminogen activator, which is a fibrinolytic agent, up to 4.5 hours. The earlier, the better. If you delay the treatment, you can have more damaged area. So after 4.5 hours, if imaging shows a large vessel occlusion, you can still go with the mechanical thrombectomy, where we pull out the thrombus with various techniques. Another important message from the slide is that this is mainly focused on the time window. So the recent studies are all coming in which we thrombolyze even after 4.5 hours, and we do thrombectomy even after 24 hours. So that means that the tissue window is more important than the time window. We will come to that later. So what are the main causes of delay in treatment? A study conducted in the US said that only 40% of the stroke patients are eligible for thrombolytic therapy, and out of that, only less than 10% receive the thrombolytic therapy. Even in the US, this is a scenario. So we don't expect anything better in India. But we should act together to improve our situation. So what are the causes of pre-hospital delay? The foremost reason for delay is not identifying symptom as stroke. So the patient themselves should feel that there is something wrong with them, and they should understand that facial deviation is not just high hypertension, high BP. So it is a symptom of stroke. So we need community level education and awareness. And second important thing is reaching a stroke ready center. So as I told, patient should reach where he can be effectively clinically assessed, where relevant imaging can be done and relevant IV drug can be administered. And another important area is in hospital delay. So there are certain issues in hospital. Even after they reach the emergency department, the emergency physician should understand that this is an emergency, and he should know the importance of door to needle time, which the patient, that is the time of arrival in ED to the moment you put an IV line, a peripheral IV line, and administer TPA whenever he is a candidate. So that delay is mainly because of the imaging. They come in casualty, we stabilize him, we do the relevant blood investigation, relevant only, then shift to imaging and reaches back, and he's applicable for thrombolysis, it is given. That is the time, door to needle time. And second is door to puncture. This comes in mechanical thrombectomy. That is the time of arrival in emergency department to the moment he is being punctured at the femoral artery, where we usually get vascular access in mechanical thrombectomy. And next is the puncture to recanalisation time. That means the moment you puncture and the time taken for you to completely remove the clot and the time taken for the blood to be restored. So these delays should be avoided as far as possible. And this is not just the role of the treating neurologist. It is the community has a role, the primary treating physician has a role, and then only comes the role of a hospital.
താങ്ക് യു ഡോക്ടർ ലിജോ. നമ്മളൊരു സ്ട്രോക്ക് ഐഡന്റിഫൈ ചെയ്ത് കഴിഞ്ഞാൽ ഇനിഷ്യലി എങ്ങനെയാണ് ട്രീറ്റ് ചെയ്യേണ്ടതെന്ന് ഡോക്ടർ ദീപക് പറഞ്ഞു. ഡോക്ടർ ലിജോ അതിന്റെ കുറച്ച് അഡ്വാൻസ്ഡ് ആയിട്ടുള്ള ഒരു ടെക്നിക്കലി എന്തൊക്കെ പ്രശ്നങ്ങളാണ് ഒരു സ്ട്രോക്ക് കെയറിൽ സംഭവിക്കുന്നത്, എങ്ങനെ നമുക്കത് ഓവർകം ചെയ്യാം, നമ്മുടെ ഇന്ത്യൻ സിനാരിയോയിൽ, കേരളത്തിൽ, നമ്മുടെ നാട്ടിൽ, കോട്ടയത്ത് എങ്ങനെ ഇത് വർക്കൗട്ട് ചെയ്യും എന്നുള്ള കാര്യമാണ് ഡോക്ടർ ലിജോ എക്സ്പ്ലെയിൻ ചെയ്തത്. താങ്ക് യു ഡോക്ടർ ലിജോ. നെക്സ്റ്റ് ഡോക്ടർ ജോസഫ്, നമ്മളിപ്പോൾ ഈ ഒരു സ്ട്രോക്ക് സസ്പെക്ട് ചെയ്തൊരു പേഷ്യന്റ് കാരിത്താസ് ഹോസ്പിറ്റലിൽ വന്നു എന്ന് വിചാരിക്കുന്നു. അപ്പോൾ പെരിഫറിയിൽ നിന്നൊരു ഡോക്ടർ കണ്ടിട്ട് ഇങ്ങനെ ഒരു സ്ട്രോക്ക് സസ്പെക്ട് ചെയ്യുന്നുണ്ട് എന്ന് പറഞ്ഞ് ഈ പേഷ്യന്റിനെ നമ്മൾ ഹോസ്പിറ്റലിലേക്ക് വിടുകയാണ്. അപ്പോൾ കാരിത്താസിൽ വന്നു കഴിയുമ്പോൾ എങ്ങനെയായിരിക്കും നമ്മൾ ഈ പേഷ്യന്റിനെ മാനേജ് ചെയ്യുന്നത് ഡോക്ടർ ജോസഫ്? ഇനിഷ്യലി കാണുന്നുണ്ടല്ലോ, അപ്പൊ നമ്മൾ എങ്ങനെയായിരിക്കും, നമ്മുടെ പ്ലാൻ എങ്ങനെയാണ്? വാട്ട് ആർ ദ പ്രോട്ടോകോൾ ദാറ്റ് വി ആർ പ്രാക്ടീസിങ് ഇൻ കാരിത്താസ്?
Okay, Dr. Sareesh. So what we have done that we have tried to develop a helpline number through which the community is aware of this number and they can call up the neurologist or the PRO in the Caritas hospital so that they can come. So once they come, we will be taken care of so that the pre-hospital delay can be reduced. And once the patient arrives in hospital, the in-hospital delay also has to be reduced. So what we have done is that once the patient arrives in casualty or the PRO or the helpline signals that this patient is going to arrive in casualty, we activate code stroke. And in activating code stroke means the duty doctor, the PRO, the consultant neurologist on duty, the interventional radiologist on duty, the cath lab technicians and the CT technicians, the MR technicians will be informed that acute stroke has arrived and you will be called immediately. So, and once the patient has been seen by the duty neurologist or the duty on call, which scan has to be done has to be decided. So we have made a protocol that up to 4.5 hours, all patients will be taken a CT brain with CT angiogram, so that we can assess the vessel status. And at the same time, when the CT brain and CT angiogram is ordered, the neurologist or the duty doctor will assess one thing. One is the clinical assessment, that is the National Institute of Health stroke scale, which can identify the severity of the stroke. And the patient goes for the CT and comes back with a result. And after that, there is an aspect scoring. It's an Alberta stroke programs CT scoring, through which we can see the extent of the brain is involved, which will be discussed later. And we also look whether the patient has major vessel occlusion also. If the patient has major vessel occlusion, we will give thrombolysis and then shift the patient to the cath lab. That is the plan. If the patient has arrived after 4.5 hours, again, we will assess the patient and does the National Institute of Health stroke scale. And at the same time, we'll be more interested in doing an MRI brain with MRI angiogram, because we will be able to get a more information about the penumbra or the salvageable tissue with MRI brain than with CT brain. So because there are techniques available, we have different modalities in MRI, like we can have diffusion weighted images, flare images, the MR perfusion images, by which we can assess the severity or the salvageable tissue that can be recovered. This is a synopsis of what we are. This is a stroke scale. Is a basic. This can be done by nurses also. It's basically depend upon the consciousness, the severity of the weakness, and the gait and steadiness speech. And based on this, there is a scoring system. And if there is more than 1 to 4, it's a minor stroke. If it is 5 to 15, it's a moderate stroke. It's more than the stroke point is more than 16 to 20. It's a moderate to severe stroke, and it's more than 21. It is considered as a severe stroke. So any moderate stroke will be considered for needs an aggressive emergency management like mechanical thrombectomy. Most likely it would be a large vessel occlusion.
Thank you, Dr. Joseph. Hospital ഒരു സസ്പെക്റ്റഡ് സ്ട്രോക്ക് വന്ന് പേഷ്യൻ്റ് എത്തിക്കഴിയുമ്പോൾ എങ്ങനെയാണ് നമ്മളത് ടൈം ഡിലേ കഴിവതും കുറച്ചുകൊണ്ട് ഏത് ഇമേജിംഗ് ആണ് എടുക്കേണ്ടത്, ഏത് ഇമേജിംഗ് എടുത്തതിന് ശേഷം നെക്സ്റ്റ് എങ്ങനെയാണ് പ്ലാൻ ചെയ്യുന്നത് എന്നുള്ള കാര്യങ്ങളാണ് ഇപ്പോൾ ഡോക്ടർ ജോസഫ് ഡിസ്കസ് ചെയ്തത്. അപ്പോൾ നമുക്കറിയാം ഈ പെരിഫറിയിലൊക്കെ ആകുമ്പോൾ നമുക്ക് ഏത് ഇമേജിംഗ് ആണ് എടുക്കേണ്ടത്, CT സ്കാൻ ആണോ MRI ആണോ എടുക്കേണ്ടത് എന്നതിനെ കുറിച്ച് കുറച്ച് കൺഫ്യൂഷൻ ഉണ്ട്. അതിപ്പോ ക്ലിയർ ആയി, ഡോക്ടർ ജോസഫ് അത് ക്ലിയർ ആയി പറഞ്ഞു തന്നു. അപ്പോൾ ഒരു CT എടുത്തു അല്ല MRI എടുത്തു, എന്തൊക്കെയായിരിക്കും അതിന്റെ early signs ഈ സ്ട്രോക്കിന്റെ ലക്ഷണങ്ങൾ എന്ന് ഡോക്ടർ ലിജോ ഒന്ന് പറഞ്ഞു തരാമോ? എന്തെങ്കിലും ഒരു കേസ് സിനാരിയോയിൽ നമ്മൾ കാരിത്താസിൽ വന്ന ഒരു പേഷ്യന്റ് എങ്ങനെ മാനേജ് ചെയ്തു, എങ്ങനെയായിരുന്നു ആ പേഷ്യന്റ് CT കണ്ടത് എന്നുള്ള കാര്യങ്ങളൊന്ന് പറഞ്ഞു തരാമോ?
Sure. This is a case of a 58-year-old female who is a non-case of diabetes, rheumatic heart disease, MSMR and AF. So she presented in the initial 4.5 hours. So 4.5 മണിക്കൂറിനകത്താണ് പേഷ്യന്റ് വന്ന്. പേഷ്യന്റ് dense right side weakness, right hemiplegia, aphasia. So ഞങ്ങൾ National Institute of Health stroke scale നോക്കിയപ്പോൾ it was 27. That means it's a very severe stroke. So severe stroke ആണ്, symptoms are there. So another important point in NHS's score is that if the NHS's score is more than 10, that is indicative of a large vessel occlusion. So NHS is more angle, that is the clinical clue that it's a large vessel occlusion, apart from aphasia, neglect, and all those things. So next important thing is the aspect score. So aspect score is, the full form is Alberta Stroke Program Early CT score. So this is a score devised by a Canadian group of doctors who are involved in primary stroke. There are two reasons. CT is available everywhere in the world, almost everywhere in the world. It is easy to do and cheap as well. So our device is the scoring CT based, so that everyone can use even in the periphery. So this score, there are gray-white areas. So our 10 areas selected. One is in the supraganglionic cut. You can see the right side. MCA territory M4, M5, M6 and label is selected. A, anterior cerebral artery, P, posterior cerebral artery. In the other cut, you can see that M1, M2, M3, that is peripheral light. Small C for caudate, L for lentiform, I for internal capsule, and I for insular cortex. So, in 10 areas selected, 10 points. So, a normal aspect score should be 10. You can see in the left side picture that this is again a picture of a patient with stroke. Patient stroke patient, you can see, but you can very clearly see the gray white matter differentiation is maintained. This patient with stroke, but the aspect score is 10. So he has 10 out of 10 score, even if patient is having symptom. Number patient, the aspect score is 10. That means patient parenchymal damage but clinically he is having a large vessel occlusion as per the NIHS score. So the previous slide, we can see that the right hand side, there was damages happen and the black area is the damaged area. So this is the scan of this patient. So patient in a clinically very severe stroke, but you can very well see that parenchymal cardiac damage is vannatilla, and you can see a white thing. You can see in the mid part, you can see a white thing. This is known as the dense MCA sign. So patient with clinical stroke this is the left side, left MCA. Clinically left MCA stroke patient is having dense, weakness and aphasia. So left MCA is clinically suspected. A suspicion scan, we can see that the left MC is dense. So that means it's the thrombus is seen here. So this is, I'm telling with the plain CT scan. Ideally, CT angio thrombus, but even with a plain CT scan, you can identify a large vessel occlusion if you look carefully. So this is another dense MCA sign. Sign disappearing basal ganglia sign. You can very well see the red arrow pointing at the upper side comparison. The gray white differentiation is lost. It is blurred. So that means damage is happening there. This is another picture showing the MCA dot sign. The MCA Sylvian fishery could cut the boy more like curve M2 branches, 2 divisions, superior and inferior division. You can see out a dot, that is again a thrombus. Compared to the other side, there is no dot on the other side. So that is a thrombus. And this is another is the loss of gray white differentiation. This is the last sign I want to describe. This is the insular ribbon sign. So you can see yellow arrows it's on the normal side. You can see the insular region as a worm, but on the other side, you are not seeing that appearance. This is the MRI picture to better make you understand that MRI is showing early infarct changes, which we can even pick on a CT if you see carefully. So, number patient clinically there was a large vessel occlusion, but we got only plain CT done, which is showing the dense signs. This is actually the DSA. Patient we clinically suspected a large vessel. We took immediately to the cath lab. Cath lab will the picture. This is the left ICA mold like curve, but the distal part is not seen. And you can see some vessels. These are actually external carotid artery branches. There is no perfusion in the brain. So this is the picture after we did a mechanical thrombectomy. You can very well see that the IC is going up and it is actually branch. You can see that's the branching point, the ACA, and this is the MCA. So you can very beautifully see that the vessel was occluded and we could open it in cath lab using the thrombectomy techniques. So this is the clot we restored from this patient. And this is the timing we could achieve in this patient. The dot to needle was 85 minutes. So this patient was thrombolized. That's why we give the dot to needle. As soon as the patient is reaching casualty, even if the patient is eligible for thrombectomy, we do give thrombolysis. Then only we shift to cath lab. So it was thrombolized. Then the door to puncture was attained just 120 minutes. The door to recanalization was 180 minutes.
Thank you, Dr. Lijo. നമ്മൾ ഇനിഷ്യലി ഡോക്ടർ ലിജോ ഈ കേസിൽ പ്രസന്റ് ചെയ്തത് ഒരു CT സ്കാനിൽ എങ്ങനെയാണ് നമ്മൾ ആ അക്യൂട്ട് സ്ട്രോക്ക് പിക്ചേഴ്സ് ഉള്ളത് എങ്ങനെ ഡിഫറൻഷിയേറ്റ് ചെയ്യും. പെരിഫറൽ ആണെങ്കിലും നമ്മളൊരു പേഷ്യന്റിനെ കണ്ടു കഴിഞ്ഞാൽ CT എടുക്കാൻ CT യൂണിവേഴ്സിറ്റി എല്ലായിടത്തും അവൈലബിൾ ആണ്. ആ CT എടുത്തു കഴിഞ്ഞാൽ എങ്ങനെ ആ ഒരു സ്ട്രോക്ക് വന്നിട്ടുണ്ടോ എന്ന് എങ്ങനെ ഡിഫറൻഷിയേറ്റ് ചെയ്യും എന്നുള്ളത് ഡോക്ടർ ജോ വളരെ ബ്യൂട്ടിഫുൾ ആയിട്ട് പറഞ്ഞു തന്നു. അപ്പോൾ അത് കഴിഞ്ഞിട്ട് എങ്ങനെയാണ് ചെയ്തതെന്നും DSA എടുക്കുന്ന കാര്യങ്ങളും ത്രോംബക്ടമി ചെയ്യുന്നതും ത്രോംബോളൈസ് ചെയ്യുന്ന കാര്യങ്ങളെ കുറിച്ചും ഡോക്ടർ ലിജോ പറഞ്ഞു തന്നു. നെക്സ്റ്റ് ഡോക്ടർ ലിജോ, ഇപ്പോൾ നമ്മൾ എങ്ങനെയാണ് ഇപ്പോൾ മെക്കാനിക്കൽ ത്രോംബക്ടമിയുടെ കാര്യം പറഞ്ഞല്ലോ, അപ്പോൾ അത് എങ്ങനെയാണ് നമ്മുടെ ത്രോംബക്ടമിയുടെ കാര്യങ്ങളൊക്കെ എന്തൊക്കെ ഇൻഡിക്കേഷൻസിലാണ് ത്രോംബക്ടമി ചെയ്യുന്നത്, എപ്പോഴൊക്കെയാണ് നമ്മൾ മെക്കാനിക്കൽ ത്രോംബക്ടമിക്ക് ഒരു പേഷ്യന്റിന് പോകുന്നത്, അത് എന്തെങ്കിലും ഒരു കേസ് സിനാരിയോയിൽ പറയാൻ പറ്റുമോ?
Sure. This is again a case, as you see, diabetes hypertension CAD ഉണ്ടായിരുന്നു, came from PMC irritable, and they promptly informed us prior to shifting, so we were ready. Patient reached at 2.5 hours to Caritas ED. So clinically it was a right MCS stroke. The clinical symptoms, the NIHSS score was 15, and he had a grade 0 on the left upper and lower limb. That means a left dense hemiplegia. So he was eligible for IV thrombolysis. He had no contraindication. The main contraindications are recent major surgery, any bleeding diathesis, extremes of extremes of age, you have to be cautious. Extreme sugars you can correct, and if still not improving, you can definitely go for with thrombolysis. There is no immediate improvement, and usually you should not wait for improvement after thrombolysis. You should immediately shift to cath lab, and there is nothing like a failed thrombolysis. So thrombolysis you do, they shift to cath lab. There is no point in waiting for recovery. So there are certain cases are there, people ask why patient did not improve from thrombolysis. The most important reasons are the thrombus composition, because thrombus actually consists of red RBCs, fibrin and platelets, and it's a mesh, complicated mesh of all these things. The composition may vary between patient to patient. So patients with a red cell rich clot respond well to IV thrombolysis, and those with fibrin rich clot respond least. And the thrombus length is another aspect. The longer the clot, the lesser chance of thrombolysis. The improving with IV thrombolysis. Large artery occlusion. So you can know thrombus can be, as we saw, it can be from the distal ICA to the even M2 branch, M3 branch, and small vessel which may not be seen even in angio. So the larger the occlusion, the lesser chance of responding to IV thrombolysis. And these patients are the candidates who respond to thrombectomy. And another is late thrombolysis. As I mentioned, the earlier the better. Late thrombolysis may not have improvement because the clot becomes hard as time passes. Another is insufficient dose. The actual dose is 0.9 milligram per kilogram. So people, out of fear of bleed, sometimes give a lesser dose, and where they may not have prompt response. So this is what Dr. Sareesh asked, which are the indications for mechanical thrombectomy. So any patients with a stroke who had a pre-stroke good, he was a functionally active person. That means the MRS, that means the level of activity. So that means patient is not bedbound, moribund patient, a cancer patient, nothing like that. Patient is fully active, you can go for. Next is large vessel occlusion. The larger the vessel, you can easily, the current techniques are for large vessel occlusion, but in near future, we will develop techniques which even smaller vessels, we can retrieve the clot. So currently the IC occlusion, MCA occlusion, M1 and the basilar artery are the standard indications, but M2 clots also can be done selectively in selected patients. And age more than 18, this is nothing but the study included patients only more than 18 years. That is why that criteria comes here. And NIHSS 6 is very important. So this means that patient with very minor stroke, only very small paresthesia, very low numbers, only a thalamic stroke, something like that, very small symptoms. NIHSS is not more than 6. You have to be, you have to actually the risk benefit ratio you have to calculate. The cost of the procedure you have to calculate. So that means very minor stroke. If they are not showing any deterioration, you may wait actually. Next is the aspects more than 6. As I told, if the patient is having 10 out of 10 score, that means the parenchyma is very much intact. The vessel is occluded. You can go and get the thrombus. The parenchyma is not damaged yet. But if the aspects is less than 6, that means the parenchymal damage has happened. There is no point in removing the clot because you may have recanalization, but reperfusion may not be attained in such cases. So this is that patient which was referred from Alberta. So you can see we directly went ahead with the DSA. DSA, you can see the normal ICA, you can see, and when it reaches up, you can see the T junction. This is not as the T junction. The T junction, you can see the AC is going to the right side and upwards, and it is fully open. You can see the MCA is stopping abruptly. So that means there is a clot there, and you get the red square is there where the blood flow is absent. And this is post procedure. We reopened the middle cerebral artery, and you can see that vessel started reflowing, and you can very well see the branches of MCA. And these are the picture of the clot we retrieved. And in this patient, the door to needle time was 90 minutes. So a patient, we were informed prior to shifting, patient came at 2.5 hours. So within 90 minutes, we could get imaging done and give thrombolysis, and immediately shifted to cath lab for this thing, mechanical thrombectomy, and we could achieve recanalisation at around 300 minutes. And patient improved. The patient was grade 0 when he came. The improvement is usually slow. On day 3, he had grade 3 power. And this is the picture on, I think, day 5 or 6. So this is the patient who came with grade 0 power, who had a large vessel occlusion, is actually he walked home on day 7. So that is the magic of mechanical thrombectomy.
Thank you, Dr. Lijo, for the wonderful explanation of indications of mechanical thrombectomy. And we have seen patients, 0 power ഉണ്ടായിരുന്ന പേഷ്യൻസ് നടക്കുന്ന ആ ഒരു മാജിക് ഓഫ് മെക്കാനിക്കൽ ത്രോംബക്ടമി കണ്ടു കഴിഞ്ഞു. ഡോക്ടർ സോംസരൻ നമ്മുടെ ഇന്റർവെൻഷൻ റേഡിയോളജിസ്റ്റ് ആണ്. Can you please explain what are the techniques, latest techniques, advances in mechanical thrombectomy? ഏതൊക്കെ പേഷ്യൻസിനാണ് നമുക്ക് മെക്കാനിക്കൽ thrombectomy പ്രോപ്പർ ആയിട്ട് കൊടുക്കാൻ പറ്റുന്നത്, എങ്ങനെയാണ് അത് ചെയ്യുന്നതെന്ന് can you please explain with a case scenario?
Thank you, Dr. Sareesh. Good evening to everyone. I would like to present it with a patient we had here before describing the techniques about the thrombectomy. We had a 48-year-old female, known case of cardiomyopathy. She presented with acute right hemiparesis and with motor aphasia. So NIHS score was 13. So clinically, we felt that she is a very good candidate for mechanical thrombectomy. Prior to that, we just took a CT angio, and then we found out that there was a left IC occlusion, and she was started on IV thrombolysis and then shifted for mechanical thrombectomy. So what we did in this patient was aspiration. So this is the angio images. On the left side, you can see there's complete occlusion of the internal carotid artery after the bifurcation. This is just before the clot retrieval. And then this is what the clot we retrieved. We didn't get in first attempt. We had to do some 2-3 attempts of aspiration. And then this is the post-aspiration, post-thrombectomy angiogram. We can see there's complete opacification of the entire IC. So this was a major vessel occlusion. Mechanical thrombectomy, the beauty is that it's not just only for the smaller branches, even major vessels like the internal carotid artery also can be opened up. So about the technique, there are different techniques wherein we mechanically catch hold the clot and then we try to pull it. One is with a stent, wherein we deploy the stent across the clot, and then the clot engages within the stent and then we pull it back. That's called a stent retriever. And then another technique is aspiration, like which we did in the previous case, is just placing an catheter proximal to the clot, and then we just aspirate the clot. And then there's one technique combining both the mechanical retrieval with a stent and then aspiration. So there are various devices like solitaire, preset in the market, whichever we are comfortable we can use. So this is just a close-up view of the stent retriever. We can see in the last picture that the how the clot is engaged within the stent retriever, and then once it is pulled out, we just pull it, take it out. So this is the a post 24 hours MRI of the patient, which we did. She just had a few tiny infarcts in the left temporoparietal cortex. Apart from that, she was doing very well. There was no major infarct. So this is the video of the patient. She had complete weakness on the right side, right upper limb, right lower limb, complete hemiparesis sort of. So this was the immediate effect. Actually, this patient immediately on the table itself, she started moving her limbs. Once the clot was retrieved, then itself she started moving her right upper limb and lower limbs. This is the day before her discharge, I guess. So that's the results of mechanical thrombectomy are so fast that we can assess the response on table itself about this the beauty of the technique.
Thank you, Dr.
Yeah.
Somsaran. Can you, there is a tissue window, കാര്യങ്ങളൊക്കെ പറയുന്നുണ്ട്, ടിഷ്യൂ വിൻഡോയുടെ കാര്യങ്ങൾ, അതായത് പെനംബ്ര മിസ്മാച്ച്, കോർ ഏരിയാസ്, അങ്ങനെയുള്ള അതിന് എന്തെങ്കിലും ക്ലിനിക്കൽ മിസ്മാച്ച് ഈ റേഡിയോളജിക്കലി നമ്മൾ എങ്ങനെ അത് ഡിഫറൻഷിയേറ്റ് ചെയ്യും?
Previously there were some guidelines for doing a mechanical thrombectomy, like it should be done. There are best results if it is done within 4 to 6 hours or sort of. Now there is nothing of that sort. The mechanical thrombectomy can be done up to 24 hours. Main thing we need to identify is the salvageable tissue. There is something called as core and penumbra. Core actually means the central portion of the infarct which has already necrosed, which is already dead, which won't come back to normal the function. And surrounding the core is the penumbra, which is a salvageable tissue. Means there is the blood supply there is less, but it has not completely necrosed, or it's not completely dead. So our aim is to identify the area of penumbra. So ideal patient would be a small core and with a very big penumbra. This is ideal patient for doing this thrombectomy. So rather, there are different techniques. First is by clinical assessment that we do, which is core clinical mismatch, wherein there should be high aspects and a high NIHS score. So based on that, we know the patient has a very big penumbra who is an ideal candidate for mechanical thrombectomy. Then commonly we do MR, and then MR it's with diffusion and flare mismatch. So we already know that the changes of ischemia come up early in diffusion than compared to flare. So if there is a mismatch between diffusion and flare, we can make out the penumbra. And third thing is with CT perfusion. So just give contrast, and then there are different parameters: mean cerebral blood volume, mean transit time, cerebral blood volume. Based on the different parameters, we assess what is the area of the penumbra. So
Thank you.
all these facilities we have at our hospital. Based on the patient's presentation, we just decide which is the best imaging.
Thank you, Dr. Somsaran. Thank you for the presenting the techniques, how beautifully patient recovering from complete occlusion of major vessels after mechanical thrombectomy. We നമ്മുടെ ഇമേജ് കണ്ടു, ആ വീഡിയോ കണ്ടു, ആ ലേഡി കംപ്ലീറ്റ് വീക്ക്നെസ്സിൽ നിന്നും ഫുള്ളി റിക്കവറിയിലേക്ക് വരുന്ന ആ ഒരു വീഡിയോ കണ്ടു. ഡോക്ടർ അഞ്ജു, നമ്മളൊരു സ്ട്രോക്ക് പേഷ്യൻസ് വന്നു കഴിയുമ്പോൾ നമ്മളൊരു ന്യൂറോ ക്രിട്ടിക്കൽ കെയർ ആസ്പെക്ട് എങ്ങനെയായിരിക്കും? പേഷ്യന്റിന് ഇപ്പോൾ ഒരു സസ്പെക്ടഡ് സ്ട്രോക്ക് പേഷ്യൻസിനെ നമ്മൾ എങ്ങനെയാണ് ഐസിയുയിൽ മാനേജ് ചെയ്യുന്നത്? അങ്ങനെ പേഷ്യൻസിനെ.
Good evening with everybody. All of us must be wondering, where does critical care come to play in a patient with stroke? Majorly, patients with stroke, what we are trying to perfusion injury, and also to prevent secondary brain damage. Secondary brain damage comes in the form of hypoxia, hypercarbia, acidosis, hypotension. And critical care comes to from the ER till the ICU. ER, once a patient comes in, the patient has got a large hemispheric stroke, or the patient has got a midline shift secondary to brain edema, or that the patient has got a brainstem stroke, for example, a thalamic stroke, a cerebellar stroke. These patients have got airway compromise. They may not be able to maintain their airway, and they may not be able to protect their airway because they are at high risk for aspiration. So, and when patients with GCS less than 8. So in an ER, if a patient comes fitting into these criteria with a GCS less than 8, this patient's airway has to be intubated. Similarly, the role of an anesthetist, ER physician, anesthetist, intensivist, all of them have got an equally important role in maintaining a patient with stroke. In a cath lab suite, where the patient is going for a mechanical thrombectomy, the patient has got a high BP, you have to control the blood pressure. The patient's airway becomes compromised, you have to intubate the airway. And finally, when this patient reaches the ICU, there you have to maintain protect the patient from secondary brain damage. Next is the breathing part. Once you control the airway, then you put the patient on ventilator and then you control the patient's breathing. Here, for 24 hours, for a patient with raised ICP, you maintain the carbon dioxide, the PaCO2, you maintain a normocarbia so that the cerebral perfusion is maintained. And beyond that, you may continue sedation and paralysis for a period of 24 hours. And there are various other ways where you can reduce the cerebral edema, where you give a head end elevation, you keep the head in the midline, you keep the neck in the midline, and to allow continuous venous drainage, you don't obstruct the jugular veins. So if you have to put a central line, you put the central line in the subclavian. And these are the various ways where you reduce secondary brain damage in a patient. Next is you have to manage aspiration. The various steps which I mentioned earlier helps us in management of aspiration. That's just for patients airway who is not intubated. For example, a patient who has a GCS more than 8, but then you know that the patient's cough is compromised, patient's swallowing is compromised, has got swallowing dysfunction. For such patients, you keep the patient's head end elevated, you put a nasogastric tube and you give controlled feeding and you give thorough nasal oropharyngeal suctioning, and you give regular chest physio. Next, the role of an intensivist comes to decide on whether the patient has to be extubated or a patient should go in for a tracheostomy, and that depends upon a number of factors. You should have a good cough reflex, you should have a good swallowing reflex, and your patient should be able to comprehend and should be able to obey commands. And if not, then the patient is a candidate for tracheostomy, which would be decided between 7 and 10 days of intubation. Next, the role of critical care comes in the management of an elevated blood pressure. Elevated blood pressure creates havoc in patients post-thrombolysis and in hemorrhagic strokes. Post-thrombolysis, we all know that patients, the blood pressure has to be less than 180/110. And especially in patients with subarachnoid hemorrhage and with hemorrhagic stroke, the blood pressure should be less than 150/90. And you have your various vasoactive agents, your labetalol, your hydralazine, your NTG. All of these plays a good role in management of elevated blood pressure. Induced hypertension plays a good role in patients with ischemic stroke, where you have, and also with patients with carotid artery stenosis. You know that the brain autoregulation is affected once there is a brain injury. And so you have to have higher perfusion pressures to maintain perfusion to the ischemic brain. Cerebral edema is routinely managed using mannitol, IV mannitol, but keeping eunatremia, because we know hyponatremia aggravates cerebral edema, and you use osmolar agents like mannitol for acute decrease in cerebral edema. Monitoring of elevated ICP is not routinely done in patients with stroke until and unless you have a subarachnoid hemorrhage or a hemorrhagic stroke. So in our hospital, we don't routinely monitor elevated ICP, but at times we look for the optic nerve sheath diameter. Next is the sodium management. What we do is we routinely maintain eunatremia and we prevent the occurrence of a hyponatremia. Hyperosmolar therapy is advised when you want to have acute decrease in ICP. Advocated is use of 23.4% saline, which is not used in our institute.
Hello.
Yes, Sareesh.
Thank you, Dr. Anju. She beautifully explained. She beautifully explained in a nutshell neurocritical aspects of stroke patients management. And now we proceed further with surgical aspects of stroke management. Dr. Aip, there are some scenarios we have to proceed further with surgery for stroke patients.
Thank you.
Can you please explain what are the indications and when will you proceed for surgery in stroke patients?
Thank you, Sareesh. Surgery in stroke is a different paradigm. You have to decide what type of stroke and in which types of stroke surgery is needed. Ischemic stroke is generally managed conservatively with endovascular techniques, with thrombolysis, as we have already seen so far. But in some stages where the ischemic stroke is involving more than 50% of an MCA territory or a large part of the ICA territory and is causing mass effect, the role of surgery comes for decompression, for relieving the pressure and making sure that the unaffected brain's cerebral perfusion is not affected because of this area. Then generally, we just decompress the brain and open the dura in such scenarios. Other aspect is for hemorrhagic stroke. We have been hearing about ischemic stroke so far, which composes more than 85% of the stroke in the public. 15% of stroke generally is taken as hemorrhagic, out of which most of them is primary intracerebral hemorrhage and secondary intracerebral hemorrhage, secondary to a vascular malformation or an aneurysm or a tumor or a coagulopathy, is 3 to 4% only. All hemorrhagic strokes are not indications for surgery. Most of the hemorrhagic strokes are also managed conservatively with, as Anju has already stressed, BP management, ICP monitoring, anti-edema measures, and so forth. Only when the mass effect is large and causing a lot of pressure effect do we actually need to go in for a surgery. Sometimes early surgery and relieving and removal of the hematoma may have a better outcome in terms of patient recovery and early return to life. This is just a picture which shows how a decompressive craniectomy is done. So what is that? In the first CT, you can see that there is a area of bleed which is shown as white and is causing mass effects, and there is some bad blood gone into the ventricle also, which is again a bad prognostic factor. This person needed surgery as his DCS dropped. We went ahead and did a decompressive craniectomy. You can see in the second set post-op CTs that some part of the bone has been removed and it has been decompressed. Not all of the blood was removed at that scenario, but we have created a path for the blood to flow out and the CSF blood inside the ventricle also to flow. And then he needed intensive rehabilitation and post-operative management in the hospital for more than a week or so. And after he was extubated, he was on tracheostomy initially and then needed to be decannulated and all. Later, on 2-month follow-up, we have an image which shows that the mass effect is gone. There is some residual gliosis. We cannot make any further intraventricular hemorrhage or blood in this scan. He then needed a cranioplasty. We have kept back the bone and he is now back to life with some aided support. We have to understand that more than 30 to 40% of the people in which surgery is done do not go back to life. They may remain moribund and all, but with advanced techniques and technology, more than 50% we are able to get them back to life in such scenarios. I'll just be talking briefly on, there are many secondary causes of blood, as we have said, AVMs, aneurysms, tumor bleeds, secondary to other causes. But we'll be just mentioning about aneurysms. Aneurysms are basically vascular blisters in vessels, which causes sudden rupture and subarachnoid hemorrhage. More seen in the anterior circulation and in the ICA, anterior cerebral or ACOM artery or the MCA territory. Posterior circulation bleeds are less than 15%. The treatment of aneurysms, it's a subarachnoid hemorrhage, is a life-threatening condition. Main aspects divided briefly into survival, preventing rebleed, and then management of secondary complications like vasospasm, hydrocephalus, and all. I'll just be mentioning about the types and techniques in treatment of aneurysm to prevent a rebleed. The gold standard has been clipping of the aneurysm, wherein we expose the aneurysm initially through large craniotomies, nowadays through very small keyhole, almost small craniotomies, exposing the aneurysm, putting a clip across the neck and ensuring that it doesn't bleed. This is a fail-safe technique. Usually once it is clipped, there's no recurrence of aneurysm usually, and that doesn't happen. There are other modern techniques like coiling, stenting. I think Dr. Sareesh will be mentioning.
Thank you, Dr. Ayub. He wonderfully explained when surgeons involved in stroke management. ലൈക്ക് ഇൻ ഇസ്കീമിക് സ്ട്രോക്ക് എപ്പോഴാണ് നമ്മൾ ബ്രെയിനിൽ എഡിമ കൂടുന്ന സമയത്ത് ഡീകംപ്രസ് ചെയ്യുന്നതിന്റെ റോള്, ബ്ലീഡ് വന്നിട്ട് ഹെമറാജിക് സ്ട്രോക്ക് വരുന്ന ഇൻഡിക്കേഷൻസ് ഓഫ് സർജറി എന്തൊക്കെയാണ്, അന്യൂറിസം റപ്ചർ വന്നു കഴിഞ്ഞാൽ ക്ലിപ്പ് ചെയ്യുന്നതിനെ കുറിച്ച് ഡോക്ടർ ഐപ്പ് പറഞ്ഞു. There are another technique that is called coiling. നമ്മളൊരു ഹാർട്ടിൽ കാർഡിയോളജിയിൽ ആൻജിയോപ്ലാസ്റ്റി ചെയ്യുന്നത് പോലെ പ്രസന്റ് ടെക്നിക് ഈസ് aneurysm coiling. Through the femoral artery we coil the major vessels. വെസൽസിൽ നിന്ന് വരുന്ന അന്യൂറിസംസ് കോയിൽ നമ്മൾ കോയിൽ ചെയ്യുന്ന ടെക്നിക്കാണ് ഏറ്റവും ലേറ്റസ്റ്റ് ആയിട്ടുള്ള ടെക്നിക്ക്. അപ്പോൾ അത് സം ഇൻഡിക്കേഷൻസ് ആർ ദെയർ ഫോർ കോയിലിംഗ്, ലൈക്ക് ലാർജ് അന്യൂറിസം മീൻസ് പോസ്റ്റ് സർക്കുലേഷനിൽ കാണുന്ന അന്യൂറിസംസിനാണ് കോമൺലി കോയിൽസ് ഇൻഡിക്കേറ്റ് ചെയ്യുന്നത്. വേറെ ആയിട്ട് ആന്റി സർക്കുലേഷൻ അന്യൂറിസംസിനും കോയിലിംഗ് ഇൻഡിക്കേറ്റ് ചെയ്യുന്നുണ്ട്. അപ്പോൾ നെക്സ്റ്റ് നമ്മൾ പ്രൊസീഡ് ചെയ്യുന്നത് എങ്ങനെയാണ് ഇപ്പോൾ ഒരു പേഷ്യൻസിനെ സ്ട്രോക്ക് പേഷ്യൻസ് വന്നതിന് നമ്മൾ മെക്കാനിക്കൽ ത്രോംബക്ടമി ചെയ്യുന്ന കാര്യങ്ങൾ പറഞ്ഞു, ത്രോംബോളൈസ് ചെയ്യുന്ന കാര്യങ്ങൾ പറഞ്ഞു, അന്യൂറിസം ആണെങ്കിൽ കോയിൽ ചെയ്യുന്നതും ക്ലിപ്പിംഗ് ചെയ്യുന്നതിനെ കുറിച്ചും പറഞ്ഞു. ദ മെഡിക്കൽ ട്രീറ്റ്മെന്റ്, അത് മോഡേൺ തെറാപ്യൂട്ടിക് ട്രീറ്റ്മെന്റിൽ ആന്റികോയാഗുലൻസിന് നല്ല റോളുണ്ട്. അപ്പോൾ നോവൽ ആന്റികോയാഗുലൻസിന് എന്തൊക്കെ റോളാണ് ഡോക്ടർ ജോസഫ് ഇപ്പോൾ വന്നിരിക്കുന്നത്? ആന്റികോയാഗുലൻസ് ഏതൊക്കെയാണ് നമ്മൾ യൂസ് ചെയ്യുന്നത്?
Okay, Sareesh. The oral anticoagulants in acute in stroke management is mainly indicated in patients with AF, atrial fibrillation, or a patient with cardioembolic stroke, where you have where you need to continue anticoagulation. The gold standard of the gold standard anticoagulant used is warfarin. So warfarin, we all know that it has its own side effects and difficulty in management. Warfarin is it's an indirect oral anticoagulant. It inhibits carboxylation of vitamin K dependent factors. There are newer anticoagulants like dabigatran, apixaban, and rivaroxaban, which acts directly on the direct thrombin or a 10A inhibitor. So the problem with warfarin, it has an unpredictable response. It reads routine coagulation monitoring with INR. It is a slow onset and offset of action. There are numerous food interaction, drug interaction, and moreover, it's very known to cause very likely to cause intracranial bleed. So these are the side effects of warfarin, which we were worried. So in the recent past, there are newer anticoagulants which has developed because of the newer trials, which like dabigatran, apixaban, and rivaroxaban. The advantage is that we don't need to do INR monitoring and less drug and food interactions, as efficacious or better than warfarin, and very safe and less side effects. Only thing, we cannot use this newer oral anticoagulant in a patient with prosthetic heart valve.
Okay, Dr. Joseph, thank you so much. And ചില ആളുകൾക്ക് ഒരു കൺഫ്യൂഷൻ ഉണ്ട്, വെൻ വി ക്യാൻ സ്റ്റോപ്പ് സ്റ്റാറ്റിൻ. നമ്മളെല്ലാ സ്ട്രോക്ക് പേഷ്യൻസിനും സ്റ്റാറ്റിൻസ് കൊടുക്കാറുണ്ട്, ഹൈ ഡോസ് സ്റ്റാറ്റിൻ കൊടുക്കുന്നുണ്ട്. വെൻ വിൽ ബി ഡിസ്കണ്ടിന്യൂ സ്റ്റാറ്റിൻ? സം പേഷ്യൻസ് think that they can discontinue statin after 3 months or 6 months. Is it a correct statement that we can discontinue statin, or we have to take it for a lifelong? What is the present scenario?
The present the situation is that we need to continue statin if the patient has developed a stroke or a heart disease, a coronary artery disease. It's not, statin does not only controls the blood cholesterol level, it has its other effects like antioxidant activities, anti-inflammatory activities, and antithrombotic activities, which is found to be useful in the management of stroke. So patients who have stopped statin after 6 months of acute stroke, there is increased chance of recurrent stroke after stopping statins. So it's better to continue statin in patients who have already developed an ischemic stroke.
There are some newer antiplatelets. Okay, there are some newer antiplatelets also. Routinely we use clopidogrel, we use aspirin. പല സ്റ്റഡീസിലും there are resistance to clopidogrel, resistance to aspirin അങ്ങനെയൊക്കെ കാണുന്നുണ്ട്. So പുതിയ ആന്റിപ്ലേറ്റൽസ് വരുന്നുണ്ട്. So what are the indications of newer antiplatelets in stroke management?
So as of now, we don't have any recommendation to start newer antiplatelet drugs in acute stroke. Only now, as of now, we can use only aspirin and clopidogrel, and in some cases the dipyridamole. All the group 2B3A antagonists like abciximab, iftimabad, and teriflunomide are currently not advocated in acute stroke management. We do use in interventional stroke treatment in patients who have developed, once we have opened the vessel and we see intracranial stenosis, we give do 2B3A inhibitor, but it's not used routinely and it's not been recommended as a prolonged treatment.
Okay, Dr. Deep, thank you, Dr. Joseph. Dr. Deepak, can you say some reasons for a recurrent stroke? Some people present with a stroke after 6 months, once they develop stroke, and again they recovered from the stroke, then again they develop stroke. There are some reasons. Can you please explain what are the reasons for recurrent stroke?
After any stroke, there is a chance of recurrence, but it is especially high in some types of stroke. For example, if it is a cardioembolic stroke, that means if the source of clot is from the heart, especially if there is an atrial fibrillation, or if there is a clot in the left ventricle, then the chance is high, which we can identify using a Holter or an echo monitoring. Similarly, if one of the major blood vessels, like an internal carotid artery, if there is a significant stenosis, if more than 50%, or if that is more than 70% stenosis, even with our antiplatelets, there is a higher chance of recurrence of stroke. And there are also procedures like carotid endarterectomy and stenting to take care of such issues. And especially in case of a large artery, if the stroke is resulting as a result of a major vessel issue, and if the plaque in that major vessel, if it is unstable, like if the plaque is ulcerated, or if there is a floating thrombus at the level of plaque, then the chance of recurrence is very high. And the what we see usually is the poor control of risk factors, especially in patients who have diabetes or hypertension. Usually when they skip medications, they usually don't control their sugars well, then the chance of stroke is very high, even when they continue to smoke and other things. The chance of recurrence of stroke is also very high. And rarely you can see conditions that cause vasculitis, primary or other systemic vasculitis, or in other ways. There is always a risk of stroke recurrence. These are the major things that can result in a recurrence of stroke. There are other minor things also, and there are uncommon causes, but mainly these are the issues where we see a recurrent stroke. Sareesh? Sareesh?
Yeah. Sareesh, it's, I think whether Sareesh has lost internet connection. Sareesh? Yeah. Sareesh, you are not audible. I think you can unmute. Sareesh?
Yes.
Sareesh, are you back?
Yeah, sir, Kitio.
Yeah. You can, I think Dr. Deepak has
Slide.
elaborated on the recurrence of,
Sir, thank you, Dr. Deepak. And now we are going to the rehabilitation aspect of stroke. Dr. Sheila, can you proceed with the rehabilitation aspects of stroke?
Thank you, Dr. Sareesh. Neurorehabilitation is actually important for all patients who have undergone a stroke. And for those patients who have had a minor stroke, or those who have had the fortune of coming to a center where a neurointerventional facility was available and have recovered from their major deficits, only minor deficits remain. For them, the importance of rehab would be, or their goal would be, to get them back to their previous self as much as possible. But for those subset of patients who unfortunately are unable to reach a center where neurointerventional facility was available, or for those who have had a really large territory involvement with significant deficits, for them, the goal of rehab would be to optimize their potential physically, mentally, socially, as well as vocationally. So for those for whom full recovery is not possible, rehab goals would be different. And for those who have minor deficits, their goals would be different. Rehab in general, like in the management of stroke, is a teamwork. So we work with the neurologists, the neurosurgeons, the rehab physician. We have physical therapists, occupational therapists, speech therapists, psychologists who work together to help the patient reach their maximum potential. So the toolbox would involve pharmacological agents, which would be necessary to maintain their pain, post-stroke spasticity. there would be interventions that could be given to manage their spasticity, like in specific muscle spasticity, local botulinum toxin injection or Botox injection would be helpful. That would help improve their function, as well as in those with severe stroke, with very severe spasticity, where even hygiene becomes an issue with significant spasticity, interfering with positioning. Botox helps in reduce the pain secondary to the spasticity and also makes things easier for the caregivers taking care of the hygiene aspects. Electrical stimulation, mental imagery, I would be dealing with this in the subsequent slides. Hydrotherapy, training them for getting them independent in their self-care, taking care of the speech and swallowing, bowel and bladder management, and getting them back to their previous life skills as much as possible would be the main goal here. When it comes to rehab, many times there's a misconception that rehab would be at the end of the stroke treatment. That is not true. Rehab ideally should begin in the acute phase as soon as the patient is medically stable. So here we start rehab right from the time the patient is in the ICU. Range of movement exercises are started, chest physical therapy is given. Once the patient is medically stable and is shifted to the room, the first 1 or 2 days the patient is in the room itself, bedside physical therapy is initiated. After that, once we are sure that the patient is not having any postural hypotension, no major medical issues interfering with therapy, patient is brought down to the department for a vertical tilt and vertical orientation on a tilt table like seen in the figure here. Electrical stimulation is given for the paralyzed side muscles to stimulate the activity in the muscles. For those who are able to comprehend, the patient is encouraged to voluntarily try moving the muscles while the electrical stimulation is being given. Apart from that, range of movement is continued to prevent contractures and deformities. The next aim to ensure their mobility would be to help them get their bed mobility, their balance improved. So once they achieve reasonable amount of balance in sitting, that is when they progress to standing balance within a parallel bar, initially with bracing. They are given knee braces and orthosis to support their weak ankle for those who are hemiplegic. Hydrotherapy is another modality used for patients who have significant spasticity. We have to ensure that the patient is cognitively stable, is able to indicate needs, and has reasonable trunk control before we shift them to hydrotherapy. The buoyancy of water helps them feel the weight of their limb lesser while they're underwater. Mirror therapy or mental imagery is used for basically upper limb weakness in hemiplegic spastic patients. The mental imagery, the weak side of the limb or the weak paralyzed limb is placed within the mirror box. The patient is actually moving the non-paralyzed limb, looking at the mirror. The brain is tricked into thinking that it is the non-paralyzed limb that is moving, when actually the patient is watching the mirror image of the normal limb. Occupational therapy deals with getting patients to improve their hand function, getting them independent in their self-care, or helping them participate in their self-care for those who have significant deficits. Cognitive training is another important aspect for those who have even minor deficits. Very often we may miss out cognitive deficits unless we assess it in detail. Apart from the initial therapy, modifying their architectural barriers, getting them independent will also mean giving them ability to be mobile inside their home, attaching grab bars, giving them supports within the room and to the toilet makes them more independent as far as their mobility is concerned. We've looked at the mobility aspect, the self-care, hand function aspect. Communication, especially for patients who have left-sided involvement and a right hemiplegia, aphasia is a major issue. The first step for a patient who has global aphasia, where there is no communication at all, would be to establish a yes and no communication. That would involve different aspects, giving them communication boards, pictures, using mobiles or even technology helps. There are different apps which can be used for patients to select from. to be able to help communicate their basic needs. Apart from that, swallowing is the next most important aspect of rehab. We know most patients in the initial phase may be on a Riles tube. The decision about removal of tube will be based on their cognition, their ability to comprehend how much comprehend the commands that are being given to them. So on the basis of a detailed swallowing assessment, the decision about removal of tube is taken based on whether the patient is able to take feeds adequately, safely, and without risk of aspiration. So this can be done initially if the patient is having aspiration or having cough. There are different techniques that can be tried: posture change, positioning, oromotor exercises training, changing the feed consistency, making it thick or pureed feeds makes it easier, and chances of swallowing aspiration with swallowing are lesser. If the patient continues to have subsequent aspiration even after a proper trial of a month or more, a plan for a peg feeding tube insertion is considered. So from rehab point of view, what is important is to start early, to explain the prognosis to the patient and to the bystanders, get them involved in the care right from the beginning, teaching them whether they can participate in their self-care, making them independent in their mobility, provided the patient has adequate cognition and is able to comprehend the commands. Even if it is a patient who has grade 0 power, they can be mobilized, they can be brought to a state where they can ambulate with supports, with aids, and this will mean getting them independent in their mobility. And the next step would be to getting them back to their vocation if the previous vocation is viable. If it is a sitting job, they should be able to get back to their job. So this would be the ideal rehab where the patient can go back to their vocation and be able to serve another person.
Thank you, Dr. Sheila. She beautifully explained about the rehabilitation aspect of stroke patients. Start early and recovery will be early. We all understood a different aspect of stroke management. How will we diagnose? How will we treat the patient and time? And what are the recent advances? What are the modern techniques of stroke management? About thrombolysis, about thrombectomy, about surgical indications, about recent drugs, about recent advances in pharmacological medical treatment of stroke patients, and critical care aspect we discussed, and rehabilitation aspects also discussed. So whenever a patient in periphery, they develop symptoms of stroke, think about be fast. Relatives should also have the idea of stroke. And നമ്മുടെ കെയർ ഗിവേഴ്സിനും നമ്മുടെ വീട്ടിൽ ആർക്ക് വേണമെങ്കിലും എപ്പോൾ വേണമെങ്കിലും നമുക്ക് വേണമെങ്കിലും സ്ട്രോക്ക് ഉണ്ടാകാം. ആ സ്ട്രോക്ക് ലക്ഷണങ്ങൾ കണ്ടു കഴിഞ്ഞാൽ ഇമ്മീഡിയറ്റ്ലി നമ്മൾ ഐഡന്റിഫൈ ചെയ്യുകയും എത്രയും പെട്ടെന്ന് ഹോസ്പിറ്റലിൽ എത്തുകയും ചെയ്യുക എന്നുള്ളതാണ് സ്ട്രോക്കിന്റെ മാനേജ്മെന്റിനെ സംബന്ധിച്ചിടത്തോളം ഏറ്റവും ഇമ്പോർട്ടന്റ് ആയിട്ടുള്ള കാര്യം. കാരണം വൺസ് ഒരു കംപ്ലീറ്റ് പാരലൈസിസ് വന്നു കഴിഞ്ഞാൽ ടൈം താമസിക്കുന്നതനുസരിച്ചിട്ട് തലച്ചോറിലെ കോശങ്ങൾ നശിച്ചുകൊണ്ടിരിക്കുകയും അതിൽ നിന്ന് റിക്കവറി വരാനുള്ള സാധ്യത കുറഞ്ഞു പോവുകയും ചെയ്യും. സോ ഏറ്റവും ലേറ്റസ്റ്റ് ആയിട്ടുള്ള ടെക്നോളജികൾ യൂസ് ചെയ്തുകൊണ്ട് തിരിച്ച് ലൈഫിലേക്ക് തിരിച്ചെത്താൻ നമുക്ക് സാധിക്കും. ഇപ്പോഴത്തെ സിറ്റുവേഷനിലും നമുക്ക് ആ ഒരു ലൈഫ് ത്രെട്ടനിങ് ഡിസീസ് സ്റ്റാറ്റസ് ആയ സ്ട്രോക്കിൽ നിന്ന് ജീവിതത്തിലേക്ക് തിരിച്ചു വരാൻ നമുക്കിപ്പോൾ സാധിക്കുന്നുണ്ട് എന്നുള്ളതാണ് ഈ ഒരു ഡിസ്കഷനിൽ നിന്ന് വളരെ ക്ലിയർ ആയിട്ടുള്ള കാര്യം. അപ്പോൾ ടൈം ഈസ് ബ്രെയിൻ, ഡോണ്ട് സ്റ്റേ അറ്റ് ഹോം, റീച്ച് ഹോസ്പിറ്റൽ ഫാസ്റ്റ്, അതായിരിക്കണം നമ്മുടെ ലക്ഷ്യം. ഈ വെബിനാർ കൊണ്ട് അങ്ങനെ ഒരു മെസ്സേജ് നമുക്ക് നൽകാൻ സാധിച്ചിട്ടുണ്ട് എന്ന് ഞാൻ വിചാരിക്കുന്നു. താങ്ക് യു. ദിസ് ഇസ് അവർ ന്യൂറോ ക്രിട്ടിക്കൽ കെയർ സയൻസ് ടീം. Dr. Joseph, please proceed.
Yeah. Thank you, Dr. Sareesh. And if any of you who are listening to have any doubts or any comments, can write down. We will try to answer those comments.
Dr. Joseph, Sebastian, it was an excellent webinar. Thank you very much. Excellent webinar from my previous hospital. So I'm very happy. I have got 2-3 questions. See, you have not mentioned anything about TIA. So I should assume that it is a minor stroke and the early part of the investigation should be in line with the stroke management. Am I right?
Yes, sir. So once we have TIA, So it has to be evaluated as an urgent emergency, and vessel, the angiogram has to be done. Either a Doppler or a brain angiogram has to be done to see the vessel status. If it is vessels are open, you can continue with antiplatelet treatment. If the vessels, we may have to plan for stenting or plan. So any TAA should be considered as an like unstable angina in cardiac disease. It should be considered as a serious illness.
Okay, so my second question is, see, you have not mentioned regarding the intervention for a posterior circulatory thrombus. Do you do a mechanical thrombectomy in a posterior circulatory stroke?
Yes, sir. Definitely, the posterior circulatory stroke also thrombectomy is done, but all the clinical trials as of now has not included posterior circulation in the scenario. So as of now, there is no recommendation, but it is a procedure we commonly use in posterior circulation also.
And
We do
last
mechanical
question.
yeah.
Okay, and one more question. As per the latest guideline, any patient with a atherosclerotic cardiovascular disease, the target LDL should be below 55. So are we aiming for a LDL value below 55 now?
Yes, sir. So our aim is to bring the LDL below 55. Once LDL comes below 55, we still don't stop statins, sir. We'll
No,
just
it should never be
our,
stopped. It has to be continued lifelong. Yes.
Yes, sir.
Thank you. Thank you very much.
Thank you, sir. യൂട്യൂബിൽ നമുക്ക് ക്വസ്റ്റ്യൻസ് എന്തെങ്കിലും ഡൗട്ടുകൾ ഉണ്ടെങ്കിൽ പോസ്റ്റ് ചെയ്യാം. അപ്പോൾ അതനുസരിച്ച് നമുക്ക് ക്ലാരിഫിക്കേഷൻസ് കൊടുക്കാവുന്നതാണ്.
So this is our neurosciences team, which include all our, I'm thankful to all our nurses who are the backbone of our neurosciences team, the physiotherapist, the speech therapist, Dr. Suma, who is supervising all. She's gives full support to all our activities, and I'm all thankful to our medical director as well as our hospital director for giving full support. We have a separate neurocritical 17-bedded ICU. We have separate neuro ward and neuro medicine and surgery ward, which was not possible without adequate support from the management. I'm thankful to all the management and thank to all the staff who is working behind the scene. And it's not has to be. I think we have to thank each one of you for making our department a successful one. Is there any questions that we can there in the YouTube, Dr. Sareesh?
Sir, actually, നേരത്തെ ഡോക്ടർ ലിജോ ഒരു ക്വസ്റ്റ്യൻ ചോദിച്ചിട്ടുണ്ടായിരുന്നു. ഡോക്ടർ ലിജോ, can you proceed with a question that you have a doubt?
Yeah.
Dr. Lijo?
I think the
Can you hear me? Yeah, sometimes we have a scenario. Sometimes patient does symptom develop maybe 4.5 hours, maybe come at 8 hours, 10 hours. But still, even at that time, even large vessel occlusion or the patients, sometimes they may not have severe symptoms. The reverse is also possible. Sometimes patient come at 1 hour, 2 hour, but they will have severe deficits at the onset itself. 1 hour severe dense hemiplegia, comatose large vessel occlusions. Why is there the difference like this? Some patients better the progressive, some patients slow it.
Yeah, that's yeah. So it's a very common question that asked. There are certain patients who improve, there are patients who doesn't improve. There are certain patients who show signs of improvement soon after that. We see improvement immediately once the vessel is recanalized. So sometimes we do see improvement only after 3 months of the vessel is recanalized. So this is because of the collateral flow the brain has. Brain has it is not supplied by a single artery. There is blood supply is supplied from all the 3 vessels. There is a circle of Willis which gives blood supply to the odd parts of the brain, which is adequately supported by the external carotid artery system. So there is a cerebrovascular reserve. There's a reserve that is different for different persons. So if you have a good cerebrovascular reserve and the patient we have recanalized, the patient improves fast. The patients who doesn't have a good collateral system or who have poor cerebrovascular reserve, their patient doesn't improve. So that is reason that some patients improve faster, some patients improve slow, some patients may not improve.
ഒരു ക്വസ്റ്റ്യൻ യൂട്യൂബിൽ ഉണ്ടായിരുന്നു. വാട്ട് ആർ ദ കോൺട്രാഇൻഡിക്കേഷൻസ് ഓഫ് ത്രോംബോളൈസിസ്? എല്ലാ പേഷ്യൻസിനും നമ്മൾ ത്രോംബോളൈസിസ് കൊടുക്കാൻ പറ്റത്തില്ലാത്ത സിനാരിയോസ് എന്തൊക്കെയാണ്?
Yes. Thrombolysis is generally indicated for all patients with measurable deficits. Measurable deficits are the patients you can give, not very minor stroke. There are initially there was a lot of contraindication category, but as time is passing, these contraindications are actually becoming indications. This is because initial trial level ഉപയോഗിച്ച criteria ആണ് നമ്മൾ contraindication എടുത്തിരുന്നത്. One important thing is that a major head trauma within the past 3 months. Major head trauma അല്ലെങ്കിൽ major surgery within the past 3 weeks. Active internal bleeding. Patient having coagulopathies, the platelet less than 1 lakh, INR more than 1.7. അല്ലെങ്കിൽ patients who received heparin, LMWH within the past 24 hours. Patient currently on NOACs, ഡാബിഗാർട്ടിനൊക്കെ കഴിക്കുന്ന പേഷ്യൻസ്, അങ്ങനെ കൊയാഗുലപ്പതി ഉള്ള പേഷ്യൻസിന് നമുക്ക് കൊടുക്കാൻ കോൺട്രാഇൻഡിക്കേഷൻസ് ഉണ്ട്, ബിക്കോസ് ദേ മേ ബ്ലീഡ്. ഇതല്ലാതെ previously less than 50 sugar അല്ലെ more than 400 was thought like a contraindication. Suppose less than 50 ആണ്, നമ്മൾ ഡെക്സ്ട്രോസ് കൊടുത്തിട്ടും പേഷ്യന്റ് ഇംപ്രൂവ് ചെയ്യുന്നില്ലെങ്കിൽ that patient should definitely receive thrombolysis എന്നാണ് ലേറ്റസ്റ്റ് പേപ്പേഴ്സ് പറയുന്നത്. So and high BP initially it's a relative contraindication. BP more than 220 ആണെങ്കിൽ thrombolysis ചെയ്യുകയാണെങ്കിൽ we should reduce the BP to less than 180 and then start. Another important thing is that a recent stroke, major stroke within the past 3 months. 3 months stroke വന്ന patient ആണെങ്കിൽ അവരുടെ blood-brain barrier will not be intact. So they have a higher chance of bleed if we give a thrombolytic therapy.
Thank you, Dr. Lijo. Any more questions? Anybody? What is the complication? One question, what is the complication of thrombolysis? How much risk? What are the risk of thrombolysis? അതാണ് ചോദിക്കുന്ന ഒരു ക്വസ്റ്റ്യൻ. ത്രോംബോളൈസിസ് ചെയ്യുമ്പോൾ ഉണ്ടാകുന്ന റിസ്ക് എത്രത്തോളം ഉണ്ട് എന്നുള്ളത്.
Thrombolysis ചെയ്യുമ്പോഴുള്ള റിസ്ക് എന്ന് പറഞ്ഞാൽ only less than 10% of the patients. Properly selection ആണ് ഏറ്റവും ഇമ്പോർട്ടൻറ്റ്. നമ്മൾ properly selected, if you go by the criteria, if you rule out contraindications, and there are certain things, relative contraindications എന്ന് പറയാം. അതായത് if patient is more than 80 years, age is not a bar for thrombolysis, but you have to be very cautious when you thrombolyze a patient more than 80. You have to be very cautious when the area is large, when the more than 2/3 of the area is involved in a stroke. These candidates can have a risk of hemorrhagic transformation and later development of edema. So carefully selected patients, we feel that only less than 5% they have a risk of bleed. If improperly selected patients ആണ് പലപ്പോഴും ബ്ലീഡ് ചെയ്യുമ്പോൾ നമ്മൾ ഫോളോ അപ്പ് ചെയ്യുമ്പോൾ അത് മനസ്സിലാകും the selection criteria was wrong.
ഓക്കെ, താങ്ക് യു. ഈ മെക്കാനിക്കൽ ത്രോംബക്ടമിയെ കുറിച്ചൊരു ഡൗട്ട്. മെക്കാനിക്കൽ ത്രോംബക്ടമി, ഡോക്ടർ സോംസരൻ, മെക്കാനിക്കൽ ത്രോംബക്ടമി ചെയ്യുന്ന പേഷ്യൻസിന് എത്ര ഔട്ട്കം എങ്ങനെയായിരിക്കും? എല്ലാ പേഷ്യൻസിനും സക്സസ്ഫുൾ ആയിരിക്കുമോ? വാട്ട് പെർസെന്റേജ് ഓഫ് പേഷ്യൻസ് വിൽ റിക്കവർ ഫ്രം മെക്കാനിക്കൽ ത്രോംബക്ടമി?
That actually that depends upon the time since onset, because we know once the clot has embolized and it has stuck into one of the carotid arteries, it will be a soft clot. The consistency of the clot will be soft. So there are different categories of clot. Some are fibrin rich, some are platelet rich, some are calcified plaques. So it depends upon the nature of the plaque that is it. So earlier the detection of the clot and earlier retrieval, the recanalisation rates are almost 90 to 100%. Suppose if you are doing a case within 4 to 6 hours. So and as the time passes on, the clot stiffens and it becomes a fibrous clot. So in those cases, the retrieval will be difficult. Generally, the what cases we have done here, approximately more than 70% of the cases we have opened it completely. There's complete recanalation. And sometimes it will be difficult when we have an tortuous anatomy. There's extreme tortuosity of the aorta and then extreme tortuosity of the internal carotid arteries. In such cases, there will be technical difficulty. So overall, if I have to say, in our experience here, we have more than 70 to 80% of 100% recanalation rates.
We may not, that's what, thank you, Somsaran, for that elaborate answer. But yeah, we may not see immediate recovery in all patients. We do see immediate recovery in some patients, like we had in few cases. But in all the clinical trials, they have found out the thrombectomy patients who have undergone the procedures and the patients who have not undergone the procedure, when you compare at 3 months, the patients who have undergone mechanical thrombectomy had become independent. So that was the reason for making mechanical thrombectomy a recommendation. So the recent guidelines have mentioned that it has to be done. So patients with acute ischemic stroke who have salvageable brain tissue, even after up to 24 hours, the mechanical thrombectomy, if possible, has to be done. Because the improvement may not be immediate, but it can be there at the end of 3 months.
And then just one more thing, sir. And then in these cases, we'll have to keep in mind the technical success of the mechanical thrombectomy sometimes might not correlate with the clinical improvement also, because some patients might be having cerebral edema, and post procedure some patients might have a little bit of hemorrhage, so that might delay their final outcome. So recanalisation is one thing, and then the final overall improvement of the patients can be made out only later, as Joseph said, within 2 to 3 months.
So there are patients we had we recanalized the artery. The patient had blood. Patient underwent decompressive craniectomy, and at the end of the 3 months, patient had reasonably become independent. So we should not get bad by the patient has developed bleed immediately after mechanical thrombectomy, because we have done our best to recanalize the artery, and now we can reduce the edema, and the brain has its own capacity to that neuroplasticity, which will help the patient to and with good rehabilitation, patient will definitely come out with a good result.
I'll just make a point. Over the last few years, we have seen patients who have had a stroke and we have had to operate for a large malignant infarct. And we have seen patients who post-mechanical thrombectomy had a recanalization bleed and had to have operated. I've seen that those who have had a mechanical thrombectomy, at the end of 2 to 3 months, they have a better outcome. Overall, their return to life and rehabilitation, the eventual, when you evaluate the patient on follow-up at 3 months and 6 months, they definitely do much better than people who have not had any intervention. I think it's all because of the amount of penumbra brain that we have been able to save because of that intervention. I think it is worthwhile in the long run.
If there are no more questions, shall we wind up, Dr. Sareesh? Dr. Wright, Dr. Lijo, shall we wind up?
Yes,
Dr.
yes,
Deepak?
we can wind up.
Yeah, we have the numbers of the people who are posting in our comment session. If anybody posts, we'll try and get back to you as much as possible. If you have any doubts, please post in the comment section.
Is there any need? There are some questions.
There are some questions that have come, and shall I just mention it? There's a question from Sneha. Is there any need to refer all stroke for thrombolysis? What is the criteria? I guess they have already mentioned it.
It's already been mentioned that. So basically, for IV thrombosis, so we need to get so patients who have symptoms of stroke, like be fast, like any acute onset balance issues, acute onset eye symptoms, acute onset facial deviation, acute onset arm weakness, they are considered as stroke. And these patients, if it is less than 4.5 hours, we have to get a CT scan. If there is no bleed, we have to consider thrombolysis. And if your center has CT angio, it's best. If it doesn't have CT angio, I think you can start thrombolysis, call one of the centers where you have angiogram and send the patients. Because angiogram is a must to patients with acute stroke. Without vessel status, we cannot know. Patient might improve immediately and then worsen. Patient may worsen after 2 days. So we may not be able to tell to the family that, this patient, we have given medicine and patient is still worsening. So if you don't have an angiogram in your setup, the patient doesn't have bleed, if you're confident enough, doesn't have any contraindications, you can call one of us or any neurologist, can start thrombolytic agent and send the patient to any of these stroke centers, where we can do an angiogram and see how the vessel status. If your center has angiogram, get the angiogram. If the angiogram is normal, you thrombolize and you can treat it there itself. If the angiogram is showing a large vessel occlusion, you can send it to one of the stroke centers where the patient can undergo mechanical thrombectomy. So only patients with less than 4.5 hours as of now, with no bleed in CT scan, is a criteria for thrombolysis.
I think we can wind up for now.
Okay.
Thank you all for
Thank you all.
attending the meet.
Thank you.
Thank you. Sareesh, stop ചെയ്തോ.